Hi everyone, today I'm joined by Dr. Omar Ibrik, internal medicine specialist and nephrologist working in a large hospital in Spain covering 500,000 patients. He has over 30 years of experience, and today we're going to be talking about the latest developments in the use of SGLT2 inhibitors. Welcome, Dr. Ibrik.
Yes, of course. Traditionally, SGLT2 inhibitors have been used to control of glycemic control in the type 2 diabetes, but now especially nephrologists, we know and we use it in the first line, not only for the glycemic control, also we use it to for two questions that they are demonstrated in the trials, very important trials with this medication. First of them is to use in patients with chronic kidney disease for two reasons. One, to slow the progression of the chronic kidney disease in this patient. This is what demonstrated by these trials that we'll speak later about them. And the second, to prevent a very important problem in our patients with chronic kidney disease, the problems, cardiovascular events and problems. So this medication, this kind of medication had demonstrated to achieve these goals and these results in the big trials that we know exactly, and that we have all the information about these trials that we can speak later.
Sure. So yeah, you can tell me about the trials. What is the evidence behind using it for slowing progression of CKD?
This is the summary of the most important trial in this kind of medication. That name is DAPA-CKD. DAPA is dapagliflozin. That is one of the one of the SGLT2 inhibitors that had most important trials, not only in CKD, in chronic kidney disease, also in other questions. But what we speak about in this trial, DAPA-CKD, what demonstrated 39% of reducing the risk relative ratio in what we call primary composite endpoints. More or equal 50% sustained decline in eGFR, end-stage chronic disease, renal or cardiovascular death.
Sure.
39% is very important percent.
Yeah.
Also, 44% of risk relative ratio for the renal composite, more or equal than 50% sustained decline in eGFR, end-stage chronic disease or renal death. 29% of relative risk ratio for the composite of cardiovascular death or hospitalization for heart failure, and 31% of relative risk ratio in all causes of mortality. For us as doctors, these percents, 39, 45, 29%, 31%, are very important percents in our specialty, in our and for our patient, for the prognosis of our patient, So with this big data, very important data as results, outcomes of this trial. Also, there is another trial with another medication. This is dapagliflozin with empagliflozin. The study that names it EMPA-KIDNEY. EMPA-KIDNEY, yes.
Yeah.
EMPA-KIDNEY had demonstrated the same results.
Yeah.
So
very interesting.
Yeah. Also, I can say that in the real world, our experience for daily experience with our patient say the same and demonstrated the same what of the outcomes of these trials.
Yeah, those are definitely very significant numbers, along with, experience of actually using them as well. And is there a special stage of CKD that the SGLT2 inhibitors are more beneficial for, whether it's at the beginning of the disease or towards end stage CKD?
And this is right. The conclusion of ADA of the last year, 2022, and the KDIGO guidelines of 2022 say what I will tell you. For patient with type 2 diabetes mellitus, chronic kidney disease, and eGFR more or equal 20 milliliter minute, 1.73 meter. Once initiated, the SGLT2 inhibitor can be continued until dialysis and transplantation. So we can use it, or we must use it, with any patient with chronic kidney disease, with or without diabetes mellitus, okay? With eGFR more or equal 20. Okay. And if we use it with a patient with 40, 30 milliliters of AG milliliter minute, 1.73 meter square, with or without diabetic, and the patient arrive with eGFR less than 20, we must to maintain the treatment until dialysis and transplantation.
Okay. And
this is what we do now,
Yeah, and for clinicians initiating the SGLT2 inhibitors, are there any considerations that they need to be careful of or to consider?
Yes, the first time that we use in the first month, and we know it very well, and we know why it's this question is what you say here about transit deep in eGFR. If we understand well, looking for the mechanism of this medication, we understand what happened in the first time that we use it. It is transit deep in eGFR, but we must be claim and to keep claim because just 1 month later, this is what I see every day. 1 or 2 months later, the patient recover. Not only recover his eGFR, also sometimes improve it, you know. So this transit deep, it's related to the mechanism of action of this medication and the renal tubule, proximal renal tubule. The inhibition of SGLT produce a lot of glucose in urine, and glucose experience an osmotic effect.
Yes.
So this is what happened. This osmotic effect produce a little bit of dehydration in the patient and reduce the eGFR.